Welcome, everyone, to Alan Hu Foundation Mental Health Lecture Series. I'm Chi-Chun Hu, co-founder of Alan Hu Foundation and host for your webinar. Today, Dr. Gerald Nestadt will present OCD, a broad overview. We'd like to thank Three Valleys Community Foundations for funding this webinar. We'd also like to thank Mental Health Association for Chinese Communities for providing simultaneous Chinese interpretation. And thank you to Yi-Ching En for Chinese interpretation. Alan Hu Foundation's mission is to promote mental health, raise awareness, and remove stigma surrounding psychiatric disorders, and support fundamental research for cures. Please consider making a gift to Alan Hu Foundation by using the donation link in the chat box. And thank you for supporting our programs. Today, it is our great honor and privilege to introduce Dr. Gerald Nestadt. Dr. Nestadt is Rudolf Hohensarik MD and Ivan Hohensarik MD Professor of Anxiety and OCD Research at Johns Hopkins University. He completed his medical training in South Africa and his psychiatric training at the Johns Hopkins Medical Institution in Baltimore. He pursued additional training in psychiatric epidemiology. His primary academic focus is OCD, genetics, epidemiology, and computational, and has led both university-based and national collaborative groups studying the genetics of OCD. In addition to research endeavors, he has directed the Hopkins OCD Clinic and taught students and residents for the past 40 years. In this talk, Dr. Nestadt will cover the history, phenomenology, which is the study of consciousness and objects of direct experience, epidemiology, which is a study of the distribution, determinants, and control of health-related states or events in populations, and treatment options for obsessive-compulsive disorder. And this webinar is being recorded. Recordings will be available on the Alan Hu Foundation website and Alan Hu Foundation YouTube channel in about 1 to 2 weeks. Please subscribe to Alan Hu Foundation YouTube channel. And following the presentation, there will be a Q&A session. Please use the Zoom Q&A function to submit your questions. The presentation is for educational purposes only and is not intended for medical diagnosis. If you have any persistent symptoms, please seek professional help. With that, I'm turning to Dr. Nestadt. Welcome, Dr. Nestadt.
Thank you very much. I appreciate you inviting me here. I'm really honored to be here. Let me start, if I may. So today I'm going to present a very broad overview of obsessive-compulsive disorder. Actually, I probably have and definitely have too many slides and too much to say. I'm too garrulous and want to talk too much. So what I'll do is presumably or possibly skip a few slides as I proceed through these slides. And I may go relatively rapidly in certain places just so that I can get to the Q&A in time. So let me begin. If he be in a silent auditory, as at a sermon, he is afraid he shall speak aloud and unaware, something indecent, unfit to be said. This was written by Robert Burton, hence the Old English style, in The Anatomy of Melancholy in 1621. And I present this to indicate that obsessions are not a new phenomenon. Of an obsession, a fear that while he talks, he will say something indecent, even though he will not. So what are the landmarks with respect to OCD, the history, as it were, in very brief, of OCD? Well, it typically can begin before Pierre Janet, a French psychiatrist, but often is considered Janet the father of OCD. He actually described a disorder called psychasthenia at the time, but the description is that of obsessions and compulsions and OCD. In this country, OCD is fascinating to me as I began working in the field over 40 years ago. Because when I was a trainee, the prevalence of OCD was considered to be 0.04%. That's less than, 1/10 of a percentage. Until there was a study in the 1980s, an epidemiologic study, that demonstrated that there was a much higher prevalence. Oddly, not oddly, interestingly, as a consequence of that number, the fact that the rate was up to 1 to 2%, the pharmaceutical industry, for the very first time in the 1980s, decided to spend the money, obviously, ultimately for their own profits, to bring out the first drug for the treatment, medication that is, for the treatment of obsessive-compulsive disorder. And that was clomipramine. By the way, that was available in excess of 20, 30 years before that in the rest of the world. So what is OCD? Well, it really consists of the presence of an obsession or a compulsion, and typically both. An obsession is an unbidden, that is not welcome thought, though it can be an image or a vision, that intrudes and are difficult to get out of the mind, even though the individual experiencing these does not typically want them, and indeed tries hard to resist them. A compulsion, often occurring in response to the obsession, is a behavior, though it can be mental or internal, that the person feels compelled to do, even though they recognize that it's unwarranted. Now, let me spend a few minutes describing examples of obsessions. When you think of obsessions, the majority of people immediately gloam on contamination. It's probably the most publicly popular type of obsession, known obsession. And contamination is the concern that something, environment, or in contact with the individual will in some way contaminate them and harm them. But typically, it's more likely just to be have a disgusting sense to it. And often people describe it as just, to coin a colloquial term, yucky. Contamination doesn't exclusively involve dirt and germs. It may involve personalities, to say an unusual example, where people would be worried if they came too close to another person, they will be contaminated by the other person's personality and actually exhibit those traits. Aggressive obsessions are also common. An example being when driving on a highway, individuals will hear or feel a bump and feel that they must have, for sure, hit someone, even though the evidence is scanty or non-existent. And I've had patients who return over the same part of the highway over and over again for hours, checking whether they had actually hit someone. Religious obsessions are historically very famous because of the notion of what's called scrupulosity. And particularly in certain religions, individuals would go to confession over and over again, even though a single time would have sufficed. Examples of compulsions may be the simple one of cleaning, hand washing, and that hand washing is done excessively. The hand washing may be done according to certain rules, and that washing may be done in such a way, such as by counting, and the individual may then doubt whether they've actually done it adequately and have to start the ritual from square one over again. Checking that you'd locked the door or locked a car or switched off the stove is again another well-known ritual. And people will sometimes need to require themselves to actually use some method to try and remind themselves that they had checked. It's because even if they had checked, they would doubt it again. Remember, this condition is filled with doubt. I'm going to give you one example of hoarding behavior. Actually, as of the last few years, hoarding disorder has become a separate condition from OCD. But people with OCD still do hoard. This is an example of one of our patients' homes where they had to collect everything and could not discard a thing. And there's a fear that they will be missing something or losing something if they discard any item. OCD itself is diagnosed simply by the presence of obsessions and compulsions in the context of some form of disablement. At this juncture, I always feel the need to talk about obsessive-compulsive personality. Because if one goes to a cocktail party, one will often hear people say, I'm a little OCD, or I'm OCD, when often all they mean is that their style, their personality style, is a little on the extreme side with regard to perfectionism, or their preoccupation with detail or over-conscientiousness, or not trusting others to do the work and hence reluctant to delegate, and being rigid and stubborn. These features can be actually advantageous to the individual. I teach my students how to distinguish the two, OCD, from just a personality style, with this approach. Those with this kind of personality really may find difficulty. They make work too hard or not take enough vacations, but they really think others should be as good as them with regard to how hard they work or how detailed they are. They think it's the right way to be. Whereas someone with OCD hates the way they are. They do not want those thoughts. They despise those thoughts. They just cannot stop them. And they are burdened dreadfully by them. Now, I want to just let us all know and be aware that OCD, if we think it's purely a psychological phenomenon, or that we are not strong enough to resist thoughts, etc., one should be aware that there are definite and clear medical conditions that bring about exactly these phenomena. The typical example is something called Sydenham's chorea, which occurs as part of rheumatic fever, cardiac, a bacterial illness that brings on cardiac disease and a variety of other symptoms. But any lesion or any injury that affects the basal ganglion of the brain can bring about symptoms indistinguishable from obsessive-compulsive disorder. Are there risk factors, or at least environmental risk factors for OCD? When one discusses this, the first thing that comes to mind is a condition which some of you or a few of you may know, something called pandas, excuse me. It also has other names these days, or PANS these days, which stands for, let me see if I remember. So I think it's psychiatric disease, neurological disorders associated with streptococcal, something of that sort. And what really happens here, the notion is that a young child will have a streptococcal, a throat infection, go to bed and wake up the next morning with OCD, an acute, abrupt onset of OCD. And one considers that this may be an autoimmune condition. So that is certainly one environmental risk factor. Now, I have others mentioned on this slide, but none of them are really well established or impressive. Actually, when I looked at the slide earlier today, I noticed that hormonal effects are on this slide. And I see my error in that it's not an environmental effect, but a biological effect, internal effect. And while on the subject, I'll mention that. And that is that often during pregnancy or in the postpartum era, people either with pre-existing OCD or sometimes new onset OCD can occur during pregnancy and postpartum. And that is clearly, it must be related to either hormonal or immunological effects and may give us some clues as to the etiology of OCD. I bring up the slide because one of the questions asked before this presentation was, are there preventive things that one can do and to prevent OCD? And unfortunately, there really are not clear preventive approaches other than early recognition. Now, OCD is not unique to any culture. It's prevalent across cultures and across the globe. There is no socioeconomic or intellectual differences between individuals with and without OCD. But most importantly, there does seem to be a familial pattern to OCD, and that is our biggest clue with respect to understanding the etiology or causes of OCD and ultimately the pathophysiology and hopefully the treatment. The other thing one should be aware of is that OCD has more comorbidities, that is, more disorders, psychiatric disorders that occur concurrently with OCD than any other disorder. And I'll mention that in a moment. First, let's look at the prevalence of OCD. So we can just look at the first column. I'm really looking over here, where OCD is considered to be about 1% in the adult population. I was asked what the prevalences are in adolescent populations, and the answer would be about the same because the majority of cases of OCD occur during the adolescence. You can see, if you compare it to other disorders, that it's quite a substantial proportion of psychiatric disorders. So it is relatively an important disorder to take care of for our community. The features of OCD are really a chronic fluctuating course. By this, I mean that it does wax and wane, and under times of stress, it can be aggravated. But as well, it never actually goes away entirely, though it can be well managed, as we'll discuss later. Now, what about the age at onset? This is from studies that I've done, and you can see the cumulative percent, that is up to 100%. And you can see that the majority of cases have begun before the age of 21. So, and the cases begin to appear in very early age, in these 5 to 9 year old range. I mentioned comorbidity, the prevalence of other disorders. I could do a whole presentation on this subject, but I chose just to stick to one kind of disorder, the affective or the mood disorders. And you can see in the light blue are individuals with OCD, and in the light tan or light brown are the control groups. And you'll see that individuals with OCD are nearly double as likely to develop over their life course MDD, which is major depression episode, or recurrent major depression, or even bipolar disorder, which is about 4 times more likely in individuals with OCD. We would see the same pattern if we looked at anxiety disorders, the different anxiety disorders. Now, I thought it would be useful in brief just to describe what we think is going on in the brain of individuals with OCD. Now, let me be clear that this isn't entirely established, but this pattern has been recognized for in excess of 30 years. And that is that there are circuits in the brain, and this particular circuit seems to be unbalanced in individuals with OCD. And it is the circuit which goes from the cortex, that is and this is the orbitofrontal, the front part of the cortex, through to the basal ganglia here and onto the thalamus, a deeper structure in the brain. And this circuit is out of balance, we believe, or has been hypothesized, at least, in OCD. Now, let me go to talk about my hope. And my hope as an epidemiologist and OCD researcher, that it would be that genetics that would give us the clue, that would help us understand the pathophysiology, that is the mechanism, and the molecular mechanism by which OCD develops, and ultimately thereafter, how to treat it. So what is the evidence? We've had twin studies that go back showing that identical twins are double as likely to be concordant, that both have OCD, compared to fraternal twins who only share half the genetic material. We've done family studies showing that the relatives or the first-degree relatives of people with OCD are many times more likely to have OCD compared to the relatives of control subjects, be they adults or children. We've been studying genetics, or at least I started many years ago, and it's a slow process. This is the most recent development in our field. And I don't want you to, I will explain this slide. This is actually called in the genetic world a Manhattan plot. And why it's called a Manhattan plot is because you have all these peaks and looking like a skyline of a major city like Manhattan. You see this red line here. Well, for years, we've been trying to see if there was an association between any area on the genome with any condition, in this case, OCD. And only in this year have we discovered that there are many regions in the genome that are significantly associated with OCD. However, don't get too excited by this, because these associations, while significant to a minus log 10 p-value is very high, like 10 to the minus 0.08, the effect size or the amount of effect that they have or the likelihood to produce OCD is very, very small. So one could never base an understanding of OCD on any of these individual locations. I've given a very broad and brief description of OCD. Let me move on to its treatment. Now, the treatment of OCD is really, in my mostly twofold. On the one hand, medication, and the other hand, psychotherapy. And I myself, being a psychiatrist, recommend that both should be used to manage the care of someone, though each alone can be effective. So first, let's turn to medication. And the first thing I'm showing is actually the first study way back in the early 90s showing the effects of this medicine, clomipramine, the first medication ever used in the United States, or given FDA approval, based on the study, by the way, FDA approval to treat OCD. You can see this is a scale of how severe the OCD is. And this is a scale generally scored from 0 to 40. And most of the people are starting high in the high 20s before treatment is initiated. And these are two different studies, actually, that were done simultaneously. The one with the dashed lines is one study, and the one with the dark line is another study. And you can see that the cases with clomipramine went down from the late 20s down to about 15 on a scale of 0 to 40. Now, that is not a cure, and this is over 10 weeks, by the way. This is not a cure, but it's substantial decrement, and enough to let someone who's totally debilitated be well adjusted and be able to manage a full life. And you'll see that the placebo in both arms of the study had hardly any effect. In fact, the study stands out among, in my belief, among all research studies, not only psychiatric, even medical, where you do a placebo-controlled study where the placebo has no effect whatsoever. Most studies show a substantial effect by placebo in these kinds of studies. So that showed that medication can work. Since then, we found that any or many of these so-called SSRI, or selective serotonin inhibitor medications are helpful in OCD. I'm sure you've heard of them. There's medicines called fluvoxamine or Luvox, sertraline or Zoloft, fluoxetine or Prozac, paroxetine or Paxil, or citalopram or Celexa or Lexapro. They've all shown shown to be effective. What is interesting and worth noting is that a variety of while these all work for depression as well as OCD, none of the other medications that work or help or in the treatment of depression do not help for the treatment of OCD. So what are the guidelines? These are essentially the medical guidelines put out by the Psychiatric Society several years ago. And basically they're saying, as I've said, that you either use psychotherapy, which I'll talk about in the next couple of slides, or a medication, or both. And generally you need a decent length of time or trial to see if they're going to work. So with medications, about 8 to 12 weeks, or for therapy, about 13 to 20 weeks. And if they work, wonderful. And you continue those for 1 to 2 years without stopping, if they're successful. After that, you consider a gradual taper or reduction to come off them. And some people can come off them and don't have to be on them forever. And others may have to be on them at the lowest possible dose for consistently for years. Now, if these don't work, there are additional responses or additional treatments, which I'm not going to go into here, that you can employ to treat people with OCD. Let me say that what we expect is about, in the first trial, like the first medication used, we'd anticipate about 60% of people will respond to a medication, and probably about the same in therapy. Now, what about behavioral management? I use this term for therapy because the therapy should mostly be of a behavioral nature. So let me explain the cycle of OCD as seen from the perspective of a behavioral psychologist. The idea is that you have an intrusive thought of any nature, though for OCD, there's a whole host of them, but they're generally in a stereotyped range. You have the intrusive thought, and this thought is then misinterpreted internally in the mental life of the individual. It's given excess or extra weight, so that the person may begin to start worrying or thinking too much about it. This brings on anxiety, which increases, and anxiety is intolerable or hideous, as some of us know. And one doesn't want to accept anxiety, so that one will try and do anything to get rid of that anxiety. And that means you'll either avoid things related to this thought, or you'll develop a ritual that reduces that anxiety. So the anxiety will decrease, but note, only temporarily. And through a process of conditioning, this reduction in anxiety actually ends up in perpetuating this obsession, this misinterpretation, and hence the cycle carries on. So it increases the likelihood of having that thought, then the anxiety increases, etc., over and over again through this entire cycle. So here's an example to show you. So here's a mother. It may sound, this isn't an unusual thought for a mother to have this image, intrusive image of having sex with their child. I mean, I know it sounds hideous, but I've seen many patients with it. The misinterpretation here is, I must want to have this thought. I must be a horrible person. And then this brings on that intense anxiety, because who would want these thoughts? So what does the individual do? They use a technique to try and reduce this anxiety by saying, well, clearly I'm not a pedophile. I look at my body. Is there any evidence of arousal? And checking and undoing the thought. And doing that will reduce the anxiety temporarily to some. But by doing that, by testing it, you're actually giving credence to this thought, and hence it perpetuates the obsession and the anxiety. So here's another example of how to treat it. The intrusive thought in this case is the thought about suicide. Now, this isn't a thought that I want to commit suicide. Please get me clear. Let me be clear. This is a thought. Sometimes people have obsessional ideas about suicide. They don't want to, but they have this thought that maybe I will. How do I know I won't? So they avoid all the possibilities of things that could increase their risk of hurting themselves. And what do? They would, one example would be they'd reassure themselves, I'd never do that. Or they mentally replace the bad thought with some good thought, like I'm going on holiday, or some other good thought, trying to reduce the anxiety brought on by that thought. Now, in this exposure and response prevention, which is the treatment we're talking about, this can be either imaginal, that is mentally just done in the office, as it were, or in vivo, you actually do something. So in the imaginal thing, you can imagine these images and feared consequence and go over in a loop, listening over and over again to the feared thought without ever reassuring oneself. Or in the in vivo exposure, even though that sounds scary to us and even worse to the patient, you would maybe handle knives, but obviously not something severe to start with. You may start with, say, a butter knife. It can definitely not hurt you. And you can gradually work up until you can tolerate any kind of things. But you have to do this without doing any ritualization, as I've mentioned previously. And that essentially is exposure and response prevention treatment. This is just a slide of all the studies going back, in this case, from 2007 to 2010, showing where 0 would be no effect, that all these studies showed a favorable effect for the behavioral therapy, for the treatment of OCD. Now, I'd be remiss if I didn't mention everything that can be done for treatment of OCD. So there actually, believe it or not, or maybe you do, that there are actual neurosurgical management for OCD. Now, these are only done in cases where there's been failure of these other treatments that have been adequately tried. But there are surgical treatments, for instance, bilateral stereotactic cingulotomy. That's actually a very tiny lesion surgically induced in the brain. Now, this is not novel in that this has been going on and being used successfully for treatment-resistant cases probably since the 50s. I don't know the actual year to be sure. But for people who are debilitated and suffering, this can be helpful. But since then, or more recently, surgeons or scientists have developed other techniques, such as what's called deep brain stimulation, where they actually use a catheter to stimulate specific regions, and these are different regions of the brain that have been used to be stimulated, to stimulate these brains these certain areas. And you'll notice they've done trials where when they're being stimulated, the OCD symptoms go down, and when they stop the stimulation, the OCD symptoms will go up. So these really do work in a sizable or a substantial proportion of cases. There are also other ablation techniques, which I'm not covering. I should mention, because I haven't mentioned here, that there's also now a transcutaneous TMS, transcutaneous through the skin, magnetic, using a magnet stimulation. And that's another technique that is being used in the treatment of OCD. Well, I think I did good by finishing before but I'm actually in a different time zone, so before 5:45, and now I will open for questions. If I may, I received questions. Should I discuss the questions?
Yeah, I can read it to you.
I've got them on slides.
Yes, yeah, let's go through the pre-submitted.
Would you like me to do that?
First. Yes, that would be great.
So these are questions that the Foundation received in anticipation of this seminar, and they divulged them to me, and I thought I'd answer. All my answers are terse and brief and to the point, so to give space for more questions. So the first question is OCD preventable? And as I mentioned earlier, we'd need to be preventable. We'd need to have a risk factor that was mutable, and we do not as yet have one. So unfortunately, not at this time. What is the earliest age one can detect OCD features? As I showed in the graph earlier, about 5 years old, one may see them. Now, you've got to watch out, and I don't want to cause too much anxiety. A lot of young children do have behaviors that look like repetitive compulsive behaviors that are normal developmental behaviors, and you want to be sure not to call that OCD when it's not. So the best thing to do is to get professional advice. What are some strategies to support children or teens with OCD? How do parents support a child with OCD who needs constant reassurance that they are clean, for instance, or okay? Obviously, and I don't need to tell parents this, but obviously compassion, understanding, and education. But in addition to that, an important thing is not to reinforce the behavior. So it's really tempting, and I understand the parent that is tempted. I too would be tempted with my children. If the child or the adolescent says, look, please answer me, am I dirty or is this dirty? Seeking the reassurance from the parent or guardian. And the temptation is to say, no, I'll check it for you. I've checked it. It's not dirty. That only reinforces the obsession. And so one, as best as one can, and as I said, I know it's difficult, one should try not to get involved in that. And it could be with regard to any other behaviors besides cleanliness. How do parents help a teen or young adult who has OCD but refuses treatment? Now, I went through the seminars you've had, and I saw someone gave a seminar on how to deal with teens who refused treatment, and they're probably more expert than me at this. But my brief thing is, I would say resolute insistence. Don't give up. Don't go, let's say the word nuclear, if you can use that phrase, about it, but encourage gradually, kindly, with examples and suggestions to to advise the child to do it. Occasionally, it may be useful getting a family intervention, people that the adolescent trusts, to get all together to sit down and reassure the child that the intervention would be, or that the treatment would not be hideous. But I recognize how difficult this is, and it's worth getting a professional involved with you at this juncture. Now, I have to say, I've had typically I deal with more young adults. I've had young adults who are adamant against it, but afterwards, once introduced, are glad and happy that they did do that. Where can I find help or resources for a teen with OCD and ADHD? I really think that the very first thing that you need may be a bias of a psychiatrist, but I really think you need a decent psychiatric evaluation so that you know what the full extent of the condition is. Comorbidities of OCD. And here they're mentioning ASD, autistic spectrum disorder, and ADHD. Obviously, I would treat both simultaneously, but I would make sure that the OCD was treated along with the other conditions intensively. Whereas if we're talking about schizophrenia, I would suggest that we first focus on the schizophrenia and not exclusively, not initially on the OCD. What's the course and prognosis? I've already mentioned it. There's a fluctuating course, typically not a cure, but can be substantially reduced. Or even if not entirely reduced, it can be managed effectively in most cases. Are there benefits of getting treatment early on for OCD? Getting treatment early on gives a higher likelihood of successful treatment. How well can medications treat OCD? I think one can anticipate about a 60% response in the very first medication tried. But please note that with additional trials and additional approaches, a higher percentage can be obtained. Would one need medication for a lifetime? As I said in one of the slides, one would try after about 1 to 2 years to try and reduce the medication. If successful, fabulous. If not, it's not the end of the world. These medications, though with side effects, can be managed appropriately. I was asked as well to look at diagnoses in adolescence and childhood. And so I just got this, actually quite an old slide, I think 2003. It's hard to get epidemiologic data, but just to show that there's about 13.3% of the sample of 6,000 plus young people had some form of OCD diagnosis, and about 7% had some disability associated with their diagnosis. And about 1% had ADHD, and about 2%, even at this young ages, had a substance use disorder, whereas about 2% had an anxiety disorder or a depressive type of disorder. These are the questions I answered. I'm now open to additional questions. I know there's time.
Yeah, thank you, Dr. Nestadt. We have about 8 minutes, but we have about 20 questions. So this audience saying says his child has depression, anxiety, OCD, and mild autism, and tried almost all kind of medication, try all kinds of medicines, and had exposure response prevention therapy, but not much progress. So the question um, is RTMS a possible treatment if the person will not take a medication or a medication resistant?
There's no question it's worth trying. I have to go back a step and say that I've seen many people come in to see me as a second opinion. And the biggest thing I have found why people haven't responded to medication is because they haven't have had an inadequate dose of medication, or it hasn't been tried for long enough. And let me just point out this, so if I may go on. People get very scared because the FDA, and this, I have to be cautious in saying this, but I'll explain. The FDA has a certain sort of range of medication that it prescribes. And often in the treatment of OCD, I exceed that dosage schedule. But it's not unique or idiosyncratic to me. Specialists in OCD have all concurred and all agree that we need doses higher than the highest dose that the FDA recommends. And so that's one thing. And the second is duration. And so I see lots of cases. I hardly ever give up. The other thing I just want to say, which isn't answering the question, but a lot of people come in and say they cannot tolerate the medication. And I have found that if you do it exceedingly slowly and titrate very slowly with reassurance and addressing all concerns, you can eventually increase medicine. Sorry, I guess the answer was yes for RDM.
Okay, right, thank you. So next question, should parental behavior, if they have OCD, be considered an environmental factor?
Well, I suppose so. It could be considered environmental by learning. However, what I have found is that as many children of people with OCD who exhibit OCD, they have different obsessional symptoms than their parents. So they didn't learn their OCD behavior from their parents in the majority of cases.
Okay. Okay, next question. What, if any, connections is there between OCD and the Tourette syndrome?
Excellent question, which I didn't mention. Family studies of, obviously this is someone who knows the answer, family studies of Tourette's disorder find that the first-degree relatives of individuals with Tourette's often have OCD. So that there seems to be a familial relationship. However, when we've done the early genetic studies, and these are not, I don't want to suggest that these are complete, but the early genetic studies show some differences between OCD and Tourette's with regard to the genetic variants we are identifying.
Okay. How can we tell the difference between OCD and the rigid behavior in autism?
I have to say that I'm not a doctor who treats autism, and I'm not a child psychiatrist. I say that because I usually say, in response to that, that I'm interested in a verbal person who can describe that there is an obsession that has an internal mental experience to it, and that's the way I distinguish. But sometimes people with autism cannot express that, and in which case it could be very difficult. However, behaviors of autism are usually stereotyped, by which I mean they are repetitive and exactly the same, whereas you don't see necessarily that degree of stereotypy with OCD. That's a poor answer, but the best I can give.
Thank you. When you were talking about comorbidities, is the reverse so true? Meaning, are early diagnosis of a major depressive disorder and anxiety likely to develop the OCD later?
Good question, but remember the age of onset. So OCD starts very young. Major depression usually starts later. So the likelihood is that OCD will antedate any depressive episodes. The other thing to mention is that sometimes in depressive episodes, when you have depression, it can exacerbate or make the OCD worse. So it appears like the OCD is occurring like it's the OCD that's primary when it's really the depression that's primary. With regard to anxiety, again, I think they often, anxiety can be co-occur, not one before the other with regard to OCD.
Okay, if parents have the OCD personality type, are their children more likely to have a real OCD?
I should know it. I'm probably the only one that's done studies that could demonstrate that, but I don't know the answer. I doubt it. There's the rate of a personality style, an obsessional personality style, is very high, or high compared to OCD. And while people with OCD often have that personality style, there are many, many more people that have that personality style than have OCD in themselves or in their relatives.
Okay.
So no, I would say no.
Okay. Next question, is there an overlap of symptoms between schizophrenia and OCD? Is there the prevalence of comorbidity between schizophrenia and OCD?
Yes. We don't know the exact number, but probably in the 15 to 20% range of people with schizophrenia will have obsessions and compulsions. I personally don't consider that OCD. I think that just in schizophrenia, you can have a variety of different symptoms of all sorts. So yes, there is that comorbidity at about that rate that I've just mentioned. But I don't think of that as OCD, though very occasionally, the OCD can be the more detrimental or more debilitating aspect of the schizophrenic illness. But that's rare compared to the other way around.
Okay. We're about time. Let's do the last question. Is differential diagnosis possible to tell if intrusive thoughts are from schizophrenia or OCD?
Oh, absolutely. I mean, in schizophrenia, I mean, the thoughts that we're talking about are delusions, I think we're talking about. Delusions are fixed beliefs, so that there's no way you can argue someone out. If they have a delusion that they're being followed, or a thought, let's call it a thought, that they are being followed, or they are being poisoned, or they are being something else, there is no way you can talk that person out of it. They are convinced. They don't see it as an unusual or ridiculous idea. Whereas the average person with OCD, with obsessions, they will mostly, if you really push hard, will admit that they recognize that it's not really true. The idea or the thought.
Okay. Okay, we're about time, so let's end here. And thank you, Dr. Nestadt, for sharing your knowledge with us today.
Thank you very much for having me. I really appreciate it, and I hope that it contributes to reducing stigma and to increase knowledge.
Yes,
All my
thank you.
best to all.
Yeah.
Thank you.
And thank you to everyone for joining the webinar. We hope to see you again in the next webinar. This webinar is being recorded. Recordings will be available on the Alan Hu Foundation website and the Alan Hu Foundation YouTube channel in about 1 to 2 weeks. Please subscribe to Alan Hu Foundation YouTube channel. And also please help to take a moment to fill a short survey. Your input is critical for us to improve the program. I will leave the donation QR code for a few more minutes, and thank you for donating to support our programs. With that, I'm closing the webinar. Thank you, Dr. Nestadt. Thank you so much.
Thank
And
you.
thank you, everyone.
Bye-bye.
And take care. Stay well. Bye-bye.